drag them back home, right? So let us know if you want them. We'll give you your poster back. If not, we'll take care of it. So please, if you have your PowerPoint for the poster, please make sure that you send it to Tivo and Fred, and we'll share them through the Dropbox. I'll talk to you later. Thank you.
Thanks, Marina. All right, well, good morning, and I'm really pleased to introduce this session on one of the clinical applications for biophotonics. And we've got three speakers this morning. The first is Dr. Labriola from Carle Foundation Hospital. She's an ophthalmologist and an expert in OCT and using OCT for ophthalmology applications. And I've asked her to come speak to you because you've heard a little bit about OCT last week, and this is really kind of the clinical end. Ophthalmology has been really the primary application, clinical application for OCT, and I think she'll walk us through what's been known and what she's doing. So thanks
Great.
again.
Great. Thanks for having me here. And I'll put my timer on so I don't talk too much. Okay. Well, this is really exciting to be in front of all of you today, because what I do wouldn't exist without the engineers and the researchers behind OCT and without Dr. Bopart, because their group in Mass Eye really came together and made this technology that changed the way we approach all patients with eye disease. And what I hope to do today is show you a little bit of our understanding from the clinical aspect, how we use, what features we use about the OCT device, and then cases that really exemplify how we use it in so many parts of our day, from diagnosis to treatment to management. So as you all know, we'll start with the basics here too. So to evaluate the eye, it is easy to evaluate the front structures of the eye. You have good microscopes and illustrations of that, but to get to the retina, it's much more challenging. It becomes an optical problem. This is the pictures that we've been using. These are 50-degree fundus photos. Initially, fundus photos started with 30 degrees, so even less space. The 50 degrees we thought was a big step forward, but obviously we're not getting much information here. A two-dimensional picture. So if patients have retinal problems, which is basically all of the orange background here is the retina. The optic nerve comes up through the back of the eye, inserts here, and the optic nerve fibers go around in different striations, take the signal that comes in through the lens and transmits it to the optic nerve, arteries and veins that transverse through the retina. In general, it's interesting to compare this to how animals' eyes develop, and in our eyes, we're almost at a disadvantage because our neurosensory retina that takes the picture is on the surface, and all of that information has to get down to the photoreceptors, and we'll see how that works. And the challenge is that the arteries and veins have a lot of diseases that we can recognize daily, from diabetes, high blood pressure, and we can diagnose that by looking at the patients, but when there's problems in the vessels, they're right next to the retina. And so it can destroy the neurosensory tissue that makes the image in the brain. So this was very limited until they developed the time domain interferometry and the OCT device that helps us to get the signal. Because the challenge always was, what depth were we looking at in the retina? How do you resolve that two-dimensional image into see where depth is? And so they came out with a super luminescent diode, goes through the splitter, which I'm sure you guys are familiar with, and it hits both the reference mirror and the retina at the same time. So that way we have some depth perception of what we're looking at for tissue, and then it goes to the detector. So as slow as that animation was, it's as slow as those images were captured, and that's what gave us the time domain image. So have you guys seen these images? How many people are working with this on a daily basis? Or okay, great. So we can go through some of the specifics a little bit more quickly, but basically what happened was, this is a moving reference arms, 400 A scans per second, acquires the raster lines, but if it acquires a line and the patient moves, the image produced might not be exactly where we think that it is in the eye. So here are kind of the summary of that. The foveal center point theoretically goes to the fovea, but it requires very good fixation, and a lot of the diseases we use, patients cannot fixate, so that was really a limitation. Patients move around, the low standard deviation, the line may not represent that plane like we talked about, and the measurements were really inconsistent. So although this really showed us a whole new way of looking at the retina, having the spectrodomain technology advanced that. So you can see the numbers are much better. With the spectrometer and the fixed reference arm, we acquire scans much more quickly. But I would have to say that in clinical practice, the majority of retina specialists are still using time domain just because of the expense and really, I think the ability to interpret spectral domain, the sophistication of reading those images, people are still on time domain. So we're looking for ways of making spectral domain technology more accessible, and the reason is just the amount of image you get in these scans. So as you can see, there's been a debate in clinical researchers about, do we really need spectral domain? Well, the time domain sensitivity specificity is good, but better sensitivity with the spectral domain, as you can see. The ability to analyze the retina with the positive predictive value, negative predictive value of finding disease, still room for improvement. So although this is used 100% in retinal practices, we're not getting there's room for more advances. So again, the time domain image would take a scan through the retina and we would see a lesion like this, low reflectivity. But actually with the same patient who was re-imaged with spectral domain, this probably represents a vitelliform deposit, which is common to see in patients who have a genetic predisposition to macular degeneration. And these patients were included in studies for treatments and labeled as failures because why was that fluid still there when we were treating them with medicine that should absorb it? And it actually was that there was no fluid there to begin with, and now with better imaging we have that. So just to highlight the difference between what time domain is, what spectral domain is, both very helpful, but we're excited for the next breakthrough that's probably going to come from someone in this room. So, okay.
Why do you think the specificity fell? Is it because more false positives, more tails?
In the spectral domain, I do think that that is the case because a lot of diseases look the same, and so it's still hard for us, especially when it comes to hemorrhage. That's something color-wise, looking at the fundus photos, we're really good at analyzing, but when it comes onto the OCT, the hemorrhage can be laying right on the retina, very hyper-reflective material, and it's very confusing at that point. Is it hemorrhage? Is it exudate? Is it fiber material? And it starts to look the same. So there's where specificity would be hard to roll in activity. I think the other thing is when we start to see some examples, there's a lot that creates an elevation in these layers, and there is still need to differentiate, is that inflammatory material, is it fluid, and so we can see that, but yeah, hopefully it's not the interpreter. Okay, so structure of the retina, just to take a step back, and this is why, as you can see from the spectral domain striations, this is what we see histologically as well. So you have the bands of the retina become important to us. This is how we learn it clinically. And if this is our histological slide that people were using to analyze disease, obviously post-mortem or post-enucleation from the eye, and now we get this histological view real time, which is totally revolutionizing ophthalmology, like we said. So just to break down things, and we'll do this on the spectral domain, you have the outer and inner segments of the cone and rod photoreceptors. Above that is the external limiting membrane, and if we advance, I should be able to get you lines to all of these features. But to break it down, the photoreceptors here, the outer nuclear layer, outer plexiform layer where all the neurons attach to the nuclear layer, the inner nuclear layers, right here you can see all the cell bodies that attach to that, the inner plexiform layers, out the ganglion cell layers, and the nerve fiber layers. So what's interesting is that knowing the anatomy also helps us know where we are with the retina and start to be able to theorize why disease happens. If we have thinning of this outer part of the retina, we know it's damaged by the choroidal ischemia because this is a blood flow from the choroid. But if it's damaged from the inside, we associate that with the retinal vasculature. So very helpful for patients to know, is it retinal vasculature, which comes usually from diabetes, high blood pressure, or is it choroidal vasculature, a much bigger problem for the eyes? But we were never able to see that before until we got the spectral domain. And here again, walking you through the layers, the internal limiting membrane, the nerve fiber layer. We're using this a lot now to assess other diseases like glaucoma and how that's affecting, even to realize that those nerves are important as they approach the macula. For anatomy, This right here is the fovea, obviously, the foveal depression, and that depression helps get the light signal to the photoreceptors without the interference of the overlying layers of the neurosensory retina. And so our most accurate vision is here in the fovea. But this is considered all the macula anatomically, and we look at the structures within the retina and also the choroid now to look for that healthy, thick choroid, which should be about the same dimension as the neurosensory retina in the fovea. So sorry, it's overlapping. But here we have the layers, and as you go through these layers, you'll see that really the nuclear layers are dark, which we always thought was because they don't reflect the signal, but now I'm learning that they also transmit the signal too, that some of the nuclear properties. And the plexiform layers have higher reflectivity. And the three bands in the outer retina, the external limbing membrane, the inner photoreceptor segment, and the outer photoreceptor segment, sorry about that confusion, is really where I focus as a retina specialist to look at these three bands. The external limbing membrane is not a true membrane, but just tight junctions between the photoreceptor cells. And then the integrity of the outer segments is really where people are focusing now to understand disease. So as much as these images and technology are developing, so is our understanding of the different layers. And what's interesting is every 3 years or so, these layers get renamed. So hopefully we'll be able to figure out exactly what we're looking at with each layer. And this was a really controversial of, people were using this ISOS junction, meaning the inner segment, outer segment for that middle band. But this was a really nice paper and, led me to adopt that it's all inner segment. And what we see is when we're looking for high reflectivity, it's really in that ellipsoid section because it's packed full of mitochondria. That's what is our theory of what gives us a higher reflectivity, all in the inner segment. So we call the inner segment ellipsoid. And these are the structures of the photoreceptors with the myoid, ellipsoid, names to the different parts of the cones and rods. And that's where that name comes from. So now moving on to clinically. Any questions so far, structure? Okay, so now we get into the fun stuff, the clinical. So how is this information, once it's gathered, given to the clinician? Well, the OCT map has been tried to be used because it's so convenient to get just a one-page printout of what's going on. You can get elevations in warmer colors and depression in cooler colors, and one quick scan through the middle, and this patient has an epiretinal membrane. Obviously, with a two-dimensional examination of the eye, this could be completely missed, and this patient could be complaining of distortions, and we wouldn't know, and the OCT has changed this. So here, what happens to get this image is you have a lining of the B scan, so you take it in a raster pattern all the way across and all the way down. It aligns the B scans, and then you get this thickness and volume map. So this is where we are. This is neat because this is a video, so not only does this help to plan surgically, so if I was a surgeon wanting to remove that epiretinal membrane, which is the treatment, I can see exactly where it is. They use stains once they go into the eye, grab that tissue and pull it. Now we're also using OCT to find all of the surgical complications that sometimes when people pull epiretinal membranes, they actually pull the retina with it. So patients will come in with these missing layers of nerve fiber and ganglion cell layers, really sometimes even into the inner nuclear layers. And the patient's complaining, I'm not seeing well, and we're like, well, this is why, because unfortunately that is a surgical complication. It's even if you put your forceps down into these places, sometimes you can leave a divot there. And I think that an intraoperative OCT is going to very much advance the next levels of retina surgeons. They're really looking forward to it for complicated cases where they can be assured that they have all the pathology removed, but not the healthy part of the retina. So this helped and guide this case. Another way of looking at the materials, and what we're trying to encourage as specialists in medical retina, is that we have all of this information. Let's not rely just on the map, which most of our physicians do, but let's look at all the scans available. 128 scans are taken to make those volume scans, and we're encouraging people to really get in there and look. And as we look, this is the way we're trained to look at the reflectivity of the retina, the nerve fiber layer, for instance, or the RPE, to see if there's breaks or missing layers, to look at the medium, to look at if, so all this is reflective. So these layers have high reflectivity, these have medium reflectivity, and these have low reflectivity. And then this is what we were talking about, to try to look at the morphology of the retina. When you're describing it in clinical terms, you want to say, is it high reflectivity or low reflectivity, and then add, are there diffuse changes of swelling or cystic changes that are there? Are the changes symmetrical or asymmetrical? That could give you an idea of the diagnosis. Subretinal space becomes very important, and this is probably where we lose our specificity. So this disease, macular hole. This is really changed by OCT. As you can see, this patient has a macular hole. Even our classification, our wording of it, is completely different now that we can actually see what layers it's affecting. Because face on, this looks the same as this. The trouble of someone's vision at this level is very mild. This patient only has 20/40 vision, so this is still drivable, usable vision. Mild distortion, we wouldn't recommend any treatment at this time because they're too good for surgery. The surgery still has those complications. There's a new medicine called Jetrea, ocreoplasmin, which can dissolve the traction here, plasmin lysis, but that's still being studied on safety. However, this patient, which might look the same clinically, really has a full thickness hole. That entire neurosensory retina is separated. The reason we hypothesize is that this epiretinal membrane, which is causing these striations, it's pulling on the retina, creating that gap, and it breaks there. So this is actually a common problem. We see this often. It's one of the main surgeries that people do. It can happen to anyone. We're not sure of risk factors. Sometimes it's when people start to get floaters or infections in the eyes, trauma or prior surgery, but a lot of people get it with none of those known risk factors, so it can also be just idiopathic, which is a fancy way of saying we don't know in medicine, if anyone tells you that word. So vision here is basically just seeing the big E on the eye chart. So drastic difference, again, different surgical approaches, and now we can really manage. I wanted to include some histology again to see just exactly how great OCT is in looking at the structure of the retina. So as we talked about, one dilemma is that as they're made, the vessels go through the neurosensory retina. So if there's problems with the vessels, there's problems with the retina. This is an example of a vein occlusion. We're not sure still where that vein gets occluded. Our hypothesis is that because the artery and vein share a common sheath, the arteries can get hard in atherosclerotic disease, push on the vein, cause a backup in flow. VEGF is released, which is vascular endothelial growth factor, and then that causes swelling within the retina. This swelling in the retina, I tell patients it's like looking through water because there is water on their eye. And the longer it's there, the more it erodes and it's corrosive to the neurosensory retina underneath, so the sooner we have to treat it. And thankfully, we have treatment now. So just as this OCT imaging is coming out, our treatments are emerging, and that's really changing what we used to do for patients. Before, we would say we have no treatment. We'd watch these patients, and they go slowly down in their vision as that fluid sat there. Now we actually inject medicine into their eye, and it absorbs that fluid. But all fluid's not as easy to treat. It's not all equal. Macular cysts can be more thick in different places and asymmetrical. And fluid, what we're trying to do is, where is the fluid? Is it in the retina? Is it under the retina? And does that make a difference of how bad it is for the retina? At this time, we believe, yes, intraretinal fluid and cysts, not as bad. Subretinal fluid, really devastating for vision. So we have to treat subretinal fluid as soon as possible. Intraretinal fluid, based on studies from vein occlusions, we think 3 months before there's permanent damage that sets in for that fluid being there. So clinical cases, I'll get into the fun stuff more now. So this 36-year-old female presents. She lives in Honduras. She flies into Los Angeles, and she tries to get treatment for her diabetic macular edema. Diabetes is still the #1 cause of vision loss in working age adults, and really prevalent in groups of patients who just have never sought out medical care. So the way that it can blind you is it can collect that fluid in the center of the vision and is not treated. So clinically, before OCT, this is what we had to work with, a picture. Well, is there fluid here? What's the problem? And now we can see with OCT, we can cut right through that. So this patient, these were her pictures. We can say that this is her fluid that she started with. This is what it looks clinically. And her treatment led to her, at first she started at 20/20 vision, but then fluid started to develop here. So you can see the subtle cystoid changes, the thickness on the map. Maps can be helpful for diabetes. Over time, she worsened to develop really these cystoid changes all the way through here, and this is what suddenly dropped her vision. Being able to see the worsening of her fluid in a short period of time let the examiners know that something more was going on here. Obviously, her hemoglobin A1C was very uncontrolled, but this needed more than just injection. She was not responsive. She needed laser because of the time in between, and so that really changed our management, being able to see it on OCT. And her vision, unfortunately, can stay stable even if the edema goes away. And one thing we need in diabetes is to know what's the most sensitive marker here of all this information on the map. Sometimes people try to rely just on the thickness in the central subfield, which is right here. But some investigators in LA, my mentor, really feels the volume measurements are more important. And I know there are studies out of your group here with Ryan and his team to look at which layers is diabetic disease really affecting the most, because that can guide our treatment. If it's in the center of the vision, we can do injections, we can treat with laser. All of our markers in clinical trials are still using other devices like fundus photography, clinical exam for when to treat, but hopefully in the next couple years, OCT will really guide our treatment. Here's another patient, a 43-year-old female with sun and vision loss, except this was only in one eye, not both eyes. And she was diagnosed with a vein occlusion because of that. Similar swelling, anti-VEGF medications weren't working, and I'll walk you through her case. So at baseline in 2010 in August, she was 20/60. Again, with this much fluid, really, this would be not drivable vision. So even that little bit of fluid is changing her quality of life. Injections, which usually absorb intraretinal fluid instantaneously, weren't working. Vision was staying stable. Third injection, fourth injection, seeing maybe does she respond and rebound back. And so this is where having a higher level of understanding of the OCT, she's just staying the same. She's developing that subretinal fluid. She's probably even getting worse. And these vein occlusion patients have high levels of VEGF for so long. This is common. There was a decision to change her therapy of all these options to be changed to Lucentis. And then after one injection, she improved. So here is how OCT shows the treating physician that, stop injecting the same medicine over and over, because injections have risks, you're not getting a benefit, and now you can judge the outcome of you can show that to the patient, they're more willing to go through treatment, it's helpful. This might be hard to see here, but this is how OCT diagnose a disease. So again, hard for you guys to see and hard for the clinician, but this artery is occluded, there's no blood flow in this lower artery. We can see that because, again, as we know the anatomy, retinal, arterial, and venous blood flow in inner retina, choroidal blood flow outer retina. So this edema and swelling is all because there is basically a stroke in the inner eye causing that swelling in the inner retina. So this patient goes completely blind this is a blinding disease, because just like a stroke in the brain, you can lose that vision. This patient, unfortunately, wherever that is, becomes completely dark and we're not able to replace it. We're also able to use a fluorescein test and show that this dye should enter within 10 seconds. She's so delayed, and the arteries are barely filling and completely not filling down here. And that's because of the diagnosis of arterial occlusion. This patient, just because of the atrophy of the nerves after that kind of intense insult and poor blood flow, you can see the entire inside neuroretina is gone, but the photoreceptors are completely healthy. And these patients right now have no treatment. So hopefully one day we can do transplantations or stem cells, different layers are being looked at to transplant into patients. But it's really, you see so much healthy retina, but this patient has complete black scotoma wherever the neurosensory retina is missing there too. So it talks about looking at anatomy. This patient, this is a 41-year-old female with progressive vision loss, and this is showing you an autofluorescence image, and it's stippling of the support cells, the retina pigment epithelial cells. Everywhere it's black is unhealthy. These patients, this is her visual field. Tunnel vision, is that what we describe when we see that? And in a young patient with tunnel vision and that kind of changes, her diagnosis becomes retinitis pigmentosa, which is really the opposite of the last patient. This is atrophy of only the photoreceptors. So the inside of the retina stays healthy. She probably has good blood flow. There's nothing wrong with her vasculature. But the photoreceptors, if you remember to look for those bands, you start to lose the bands, and you really have to look at it that specifically. This is what she has. So what's interesting is because of the way she looked, even though retinitis pigmentosa, a lot of people get grouped in, it's still a blinding disease that children are born with that affect young people early in life with nighttime vision problems. What's interesting is that we're starting to identify the genes. And if we can identify the genes, they are actually doing gene therapy for some of these patients. The subgroup that is getting gene therapy is a Leber's congenital amaurosis, if you're familiar with that disease. It's an autosomal recessive disease. So 25% chance that the baby will have that, and they're usually highly functional but completely blind, no image, no light perception. And to distinguish those patients out. And now these other subgroups, what they've done is with Labor's, they found the gene, they found it in a population of dogs. They were able to do a viral vector on an adenovirus to put in the gene that was missing into the adenovirus. They're subretinally injecting it into the eye, and now they have 5-year data on about 7 patients who are getting that in the United States, and they're having success with improvement in reading. So now we take OCT to find out what type of gene are we looking for. Is the genotype related to the phenotype on the OCT? And we're finding it is. This patient has a rod cone, but really cone atrophy. You can see the thinning here in the center because there's transmission defects, that signal coming through. These outer retinal bands are healthy here, but very atrophic on the inner. She's losing that healthy foveal reflex because of that. And here you can almost see the dipping down to signify the loss of the outer retina. So it's not typical RP. This is what typical RP looks like with cystoid changes usually, and thin retina on the outside, healthy retina on the inside, so completely opposite of what our last patient had. This patient has intact retina here, giving typical tunnel vision. Our patient had different. It led us to do a gene analysis. We found her unique gene mutation, and we were able to get her into a trial. So that's what OCT does. When you use spectral domain over time domain, you can tease out these layers. So what are other things? So subretinal fluid, I just want to give you some images. This is a disease that happens to young type A people. So probably anyone in this room, if you start getting blurred vision, you want to think of this one first. So it happens for some kind of imbalance in the choroidal blood flow. It creates these little blips. Fluid gets through the retina, causes dramatic loss in vision, but it self-resolves, a condition called central serous. We have features of OCT because of the size of that lesion and the amount of fluid. This is different, and this is a much different diagnosis. This is AMD. So same fluid, same blip in the retina, different proportions, and instead of just fluid, we think that there's really a choroidal neovascularization or new vessels growing up here to invade. And these patients, they don't self-resolve. They could be permanently scar, and this is why patients lose vision from macular degeneration. So just the difference in the morphology, those are the subtle differences that give you a whole different diagnosis. This patient actually has had such long standing that this elevation in the RPE permanently scarred this retina. These cysts are degenerative because they're not really, there's no more photoreceptors left here. And so it helps us to guide patients, tell them what they have, give them prognosis, know who we should treat. Case number 5 is a patient who came in with a rare condition that happened after he had surgery on his other eye. This eye started to get blurred, and this is also subretinal fluid, but so thick, and this is where this condition is inflammatory. So we saw so many different types of fluid. This one really has macrophages involved, we think. An inflammatory response is called sympathetic. His vision might be able to see hand waving before 1 week, 6 weeks of steroids and totally gone. So, identifying the morphology, knowing what it is, completely different treatment regimens for it. This person who improved with steroids, the central serous would have got worse with steroids. So we're really looking to how we can tell clinical people, this is one thing, this is the other, and this is the anatomy that matches up. Other changes is that instead of just loss within the retina, we talked about thinning of the inner retina, outer retina. This is thinning of the support cells, the RPE, again with that transmission defect. If that happens in the center of the vision, we can explain to people why their vision got worse without having really fluid or anything else, as the cells just start to disappear. That's dry macular degeneration. That's a leading cause of vision loss within patients 65 or older in the United States, and there's still no treatment for this. And what we're doing is looking at these features called drusen. Where are they coming from? Where are they collecting? And when we look at geographic atrophy, what's the first layer that goes? Can we replace that? Can we stop this progression? How is it extending? That's really where we're looking to try to put, should we put stem cells right here at the margins? Can we put a proton kind of complete a protein transplant right here over the whole gap to refill it? Some surgeons actually translocate the retina, take a bite out, spin it around, put it back on like Cynthia Toth and Duke does, still to try to replace that missing retina. So any cure for this kind of disease, because this is really affecting so many people. And then the choroid. So moving to outer layers, the choroid has large vessels in Haller's layers, medium vessels in Sattler's layer, and tiny choriocapillaries at the top. this is where everyone's attention is moving now. We think that it's very related to why that RP dies. It might be a blood flow issue from the choroid. Patients who have nearsightedness, this is how thin a healthy nearsighted person, this patient can see 20/20. But a weird retina, because it's bowed back because of a staphyloma, they're myopic, so their axial length is longer. They have an epiretinal membrane here. But really, what's most frightening is that the choroid blood flow is so thin. So we think that these patients, high nearsighted patients, can be at risk for features like macular degeneration. Again, we're understanding that the choroid is important only because OCT was invented. So this is a normal choroid, and to evaluate the choroid, how can we improve it? This is where a lot of focus is going. And we know that the images are taken, the closer this image is to the top of the screen is usually where the zero delay is placed. Are you guys familiar with this technology? Anyone have heard about this before? So when we take the image, there is something where the reflectivity, the reflected image is at its highest point. So you can get the most clarity from the image, and that's called the zero delay. That's where the light focuses. So the choroid is so far away from the zero delay that we lose the clarity of the choroid, especially because the signal gets interfered with the RPE. So by shifting the zero delay, by changing where the optical focus is of it, now we can get clear choroid. We can see the choroidal structures, and that's really by changing the location. You can do this on a Cirrus machine by just waiting until the reflected image inverts and then putting the choroid by the top of the image, or on a spectralis because of just a software system that lets you see that. And you can see the difference. We can start to really see those choroidal vessels. That technique was invented by Rick Spade, and he has a nice article that calls it enhanced depth imaging. So you can see healthy choroid, abnormal choroid, and now we're seeing within those structures, maybe to change the specificity, be able to see what's in these elevations. So patient with AMD, this is where it's showing us when they did these studies, the numbers behind it, the OCT sensitivity, and knowing if a patient has AMD, any kind of features from clinical comparison, pretty good, but still everyone's favoring the fluorescein angiogram. The advantage is the OCT is non-invasive, and the fluorescein is really you put a needle in someone's arm. So fundus photos in diagnosing this leaking, they get very good specificity and not here as much. And I think it's because sometimes we're not sure if it's solid and inactive, or is it active because it has this fluid cleft. These are terms that are developing now. And this is where we get all these numbers from. So this is where we need your help to make things better. Another case of, this is a 56-year-old female, and so looking at retina again, we want to look at our layers, and she's really missing her choroid. This patient was diagnosed with macular degeneration, but actually her retina is better than her choroid. She was followed for years for macular degeneration, told there was nothing to do. Looking at her OCT scan, we really found that the choroid was missing. It was the loss of the RP in choroid, and that gave us a diagnosis of choroideremia. She had a genetic predisposition to make this change. We analyzed her family. We found a mutation in her daughter, and again, it opens her up for trials that before she just was being told the wrong diagnosis, wrong prognosis, and now this is helpful. Another patient who comes in with blurred vision in his eye, and looking right under the fovea, you can see the higher reflectivity right here within that layer. This is only possible because now we're using these scans, these black and white infrared scans to really target where pathology is. And this is usually the image we get back from patients, but with systems like eye trackers, they shift everything back in focus. So even with this image, software is done to analyze it and put it back into focus. And then we can track that point over time so that we can see this thickening has improved and diagnose him as that condition. Another white dot inflammatory condition. These conditions, we don't know what happens. They look like a white appearance to the retina. Now we're able to distinguish classifications between, is it affecting inner retina? This one affects the outer retina. We can make the diagnosis better. We can use this technology of a C-scan image to see exactly where the photoreceptors are, and this is really gaining popularity within ophthalmology. The more we can do with this, and scroll down to see the level, put this plane of that raster scan at the level of the photoreceptors, and we lose reflectivity where photoreceptors are sick. This condition is called Muse, and why it's so important is that this is a patient's blind spot. If we invert it to match what the anatomy would do, this is a person's C-scan image. So now we know what part of the eye is really causing that blind spot. It was the photoreceptors. That's been discovered in the last 6 months. No one knew that. Everyone thought it was the RP before. And so this CT scan image with OCT showed us that. Adaptive optics is really, everyone's trying to get a lot of attention to adaptive optics, but it's very cumbersome to have the devices. It's hard on the patients. It's hard to image. It's exciting that we can get image all the way back through the neurosensory to where the tops of the cones are in the eye. And this is a cone mosaic. So we still can't resolve the other photoreceptors. But this is that same patient with that condition called MUDES, where when she was sick and unhealthy, the cone mosaics disappeared. Everything was in focus here similarly, but in these focal spots where she had her blind spots, the cones return. And so if we understand this disease, can we understand what makes cones just be destroyed, what makes them come back, and that's kind of where we are with OCT images. So just in summary, I think already you guys have understand the point of the OCT really revolutionized how we diagnose, how we treat, and how we manage. And all of these patients, when they walk into an eye clinic, they're getting OCT scans. We're trying to improve our way of interpreting them, but really the most exciting part of this field is how much technology is improving every day for these images. So thank you for your time. Great. And do you have any questions? I just wanted to see.
So, for the diseases, especially with like the vein occlusion or blood flow, you think you could use something like spectral variants or something to identify whether it's static or whether it's a vein or something?
Yeah, so they are trying to do that now. That's a great question because definitely in those diseases, we can see that it's static with the fluorescein, and other diseases like ocular ischemic syndrome or where there are diabetes patients who lose vision without having the swelling, is it because they're having poor blood flow? And they are trying to use the spectral variances, I think, where you get the Doppler effect of the blood flow differences, right? Yeah, they are using that now. The hard thing is looking where is the reference for it, because it's coming in different dimensions. It's 3D. The vein can go towards you or away from you, and where do they get the reference arm? But there are publications out there. They're just starting to do this. Mark Humayun has a couple papers out on it if you wanted to look into it more. He's using the same technology that they look at jet fuel to see how, with the different intensities in a snapshot. Because the other challenge is just how fast and how accurate you have to be with such a small amount of blood flow.
So I didn't know if, like, in order to take multiple scans, would that be going over the exposure limit?
No, I don't think we have an exposure limit that we know about with the eye. So it doesn't seem like it's exposure limit as far as toxicity we haven't seen. I think it's really their challenge was just getting the reference, but they are doing it. They have figured that out, and they do have the map color coding. We're not sure what to do with the information yet as far as how to restore that blood flow once we know it's thin, because we don't have any medicine to do that. So I think that's why it's just slowly advancing. Yes?
So one thing when it comes to imaging like eye or retina, is there any other optical technology that basically you use for, and basically the second question is, what do you want to see? Like basically what is lacking in OCT that you want to see coming like 5 years?
Well, there's lots of optical devices that we use to image the different parts of the eye. The wavefront technology that has been used with adaptive optics is also used with corneal topography to try to get an exact image of where everybody has different bends or defects in their cornea. So there are different ways of doing it. Optical coherence tomography is one. Then we have confocal imaging. The autofluorescence really comes down to what we do is you put a pinhole technology to filter out the wavelengths, and based on the wavelengths we can tell depth with a confocal. Most of them are being combined into one device now. I'm trying to think if there's any other, just with the light sources, it's such a unique part because everything can be really optical in some nature because you're looking through the clear media. But I think the biggest ones are the confocal laser ophthalmoscope and the OCT device. Those are the biggest ones. Where we need to improve is when we look at these images, we're still only seeing this is 6 millimeters of the back of the eye. We're not able to image really the periphery of the eye. And the degrees that we're looking at, about 50 degrees, the back of the eye is up to 120. We really want to get out further. We want to see what the peripheral retina looks like. I know the surgeons want to have the capability of using in the OR. We want to have the capability of having handheld devices to be able to give to the community so that they can screen themselves and come in when they have fluid, or just remote image their disease, so that we can say, right now, if we follow macular degeneration, that patient who's probably 90 or older, can't see, has to get a driver, comes to the office every month to see if there's fluid. And if there's some way of giving that to that patient at home, that would be great. Also, picking up diabetic disease at screenings would be great. So remote capability is a huge thing. Further extension of the image into the periphery. And always we're just trying to do higher resolution, blood flow, technologies. And then, and with higher resolution, with AMD is getting a lot of just, my thing would be, can you image the front of the eye? When the front of the eye has inflammation, can you tell what cells are inflamed? Are they white blood cells? Are they red blood cells? Are they macrophages? Would that help us say, is it bacterial? Is it viral? Too, so. Does that answer everything? Tons of ideas, so just, yes, Ryan.
Would you say that there's a large disparity in implementation between, say, an average ophthalmologist and an OCT expert? Does that cause some barriers as far as acceptance? How well OCT is being used?
Yes, there's a large variance right now. My specialty is medical retina, so I really went into just OCT interpretation. But most people who use this for retina and surgical retina people, they don't take the time to break down the layers. So one advance that we need is, I think that if you look there, my research and my fellowship was looking at the measurements we do to follow disease don't really show us disease. My research was looking at, if you look at a clinical study of treating macular degeneration, they use central subfield thickness, drop in visual acuity of 5 letters, and that's not picking up the earliest disease. So probably patients aren't doing well because they're not sophisticated enough to read the OCT image, the clinicians. Now that's changed. The last study we did on AMD, they did have reading centers interpret the images, and that really improved outcomes in patients. So we do realize that the average person treating AMD is not sophisticated in reading the OCT. When you have a reading center, treatments are better, outcomes are better. So what can we do to identify on that, all the technology that's given to the clinicians to show them which ones are most important, which numbers can they rely on? Can we make the segmentation more accurate for someone so that they can see or highlight the pathology? That would also be a big advance. And does that have to be in a spectral domain device that they have to purchase, or can we get that sophisticated image and numbers to let them know where is the cutoff of good and bad? The papers are coming out, but even if you look at the textbooks in OCT imaging, they tend to lag behind what's useful for the clinician. So the clinician, the average clinician gets their information from lectures, from publications, and there's still so much disagreement on even just naming the layers that I think that as it's evolving, people are on different pages with it. But at least there are people who are expert, and that opinion's getting more out there. And that's what I'm focusing just on retina. Now for glaucoma, this is really interesting in glaucoma because they don't look at, they tend not to use the morphology of the eye, they really look at numbers. And there, it's nicely color-coded. Green, the patient's safe, red, the patient's not safe, you should start drops. And so are we being accurate with that? And can we get that into retina? That would be cool. And now, I'm so focused on retina, but the nerve is glaucoma, optic nerve diseases, other things. There's so much possibility of refining this for looking at other diseases besides just retina too. Did that answer your question too? Yeah. Okay. Yes.
Do you know if there how the integration of reading OCT is being pushed into the curriculum for ophthalmology and optometry?
So there's not, as a resident, there's no formal way of reading OCTs introduced to residents, not a standardized approach. It's not even on the oral boards. So most of them are still just fluoresceins and fundus photos. The OCTs only introduced with the other ones because we're not expecting them to be able to read that at that level. Hopefully that will change. That's a great question. When I was at Pittsburgh before I came out here, and we introduced it. The gold standard was fluorescein angiography. They had these things called FA rounds. Now that's moving to imaging rounds, and FA rounds are really OCT, which is funny because there's no angiography in some lectures anymore. But really, I listen to lectures that the fellows are teaching and their terminology's off. There's no consistency. We really have to be better about that too. So, yes.
What's your impression of clinical interest in adoption of adaptive optics?
I think I do think that from the people who are at the reading centers and the tertiary referral centers, it's high because a lot of diseases were devastating vision loss at the photoreceptor. That's what we want to know what's going on. What I'm seeing with infectious diseases, it mostly affects the photoreceptors, and it's really changing how we approach infectious diseases in the eye. However, the people in the community who are still using time domain, that's the majority, and there would be no rule for it at the level of the cost point of it and the expertise you have to have. Most people in day-to-day practice don't even have a dedicated photographer, so it has to be user-friendly for their staff to do as well too. So definitely a lot of research, a lot of excitement with it. But even very prestigious universities who don't have access to the technology of it are just looking to the OCT instead, trying to make that C-scan image replace what the adaptive optics would do. So, interesting.
Okay. Well, looks like Dr. Labriola. Thank you very much.
Sure.
So why don't we break for maybe about 10, 12 minutes or so, and we'll